Hi everyone, and in this video I'll be discussing pharmacotherapy of CHF. So CHF stands for congestive heart failure. The name itself is telling you heart has failed because of there is congestion. Congestion here means the edema. So the fluid accumulates not only in the lung. If it accumulates in the lung, it is called pulmonary edema. In the periphery, it can accumulate and cause edema in the periphery, ascites, as well as increase in GBP. So there are two types of heart failure. One is the acute heart failure and one more is chronic heart failure. Acute heart failure is also called as decompensated heart failure and chronic is also called as compensated heart failure. Now in acute heart failure, the reason, most common reason is during MI the heart may fail suddenly and patient may go for acute CHF. So acute CHF is an emergency and we have to manage it. Chronic CHF is also managed, but it's not an emergency comparative to acute CHF. So let us understand what are the drugs used in CHF and we'll discuss one by one in this video. So let us start CHF. What are the drugs for CHF? So the full form is congestive heart failure. So the heart has failed and because of that there is congestion. In congestive heart failure, we have two types: acute CHF, acute congestive heart failure, and one more is called chronic CHF. Now, acute CHF is also called as decompensated heart failure. So, the meaning of decompensated means it has not compensated and you have to manage immediately. Chronic is also called as compensated heart failure. So, these are the two things. Now, let us first understand what are the drugs used in acute CHF and then come to the chronic CHF. So let us understand the management of acute CHF. So let us take an example. Suppose a patient had MI and he had heart failure. Now let me draw the heart. This is the heart. Yes. And let me divide it into left and right. Now suppose if the left ventricular failure occurs, what happens? If the left ventricular failure occurs, the heart is not able to pump the blood properly and the blood remains and the back pressure is given back to the lungs. So let me draw the lungs. So the back pressure is given to the lung and the edema fluid accumulates in the lung. So we call it as pulmonary edema. So we call it as pulmonary edema. So when the left ventricular failure occurs, there is pulmonary edema. Suppose there is a failure of right heart. So right heart failure, the pressure is back on the superior vena cava as well as inferior vena cava. So the pressure which is seen is like this. There is increase in jugular venous pressure and what we see is peripheral edema. What we see is peripheral edema. Now because everywhere the fluid is accumulated, we call it as congestion and it is called congestive and heart is not able to pump the blood properly. It is called congestive heart failure. Now first thing what we need to take care in acute CHF is remove that excessive fluid. So that is why the diuretic of choice in pulmonary edema, can you take a guess? What is the diuretic of choice in pulmonary edema? It is the loop diuretics. And in loop diuretics, the commonly used one is furosemide. Now what is the reason why do we use furosemide? I told you already in loop diuretic because they produce vasodilatory prostaglandins. So these vasodilatory prostaglandins in LVF they cause venodilation and by causing venodilation they will shift the blood from pulmonary to systemic circulation. They will shift the blood from pulmonary to systemic circulation. So what is the advantage when you shift the blood from pulmonary to systemic circulation? When there is pulmonary edema, patient will have difficulty in breathing, so the dyspnea comes down. And later, the action of furosemide acts as diuretic and remove the fluid. So later, the diuretic action come to the picture and it removes the edema fluid. So please understand the major action of furosemide is venodilation in pulmonary edema. Later, the diuretic action comes to the picture. Now, what is the diuretic contraindicated in pulmonary edema? In pulmonary edema, the diuretic contraindicated, yes, what is your guess for that? Yes, obviously the osmotic diuretic mannitol. Why mannitol is not used? Because in left ventricular failure or pulmonary edema, already heart is failing and this mannitol increases ECF. So when you increase ECF, that is blood volume, the workload on the heart increases and the heart will fail further and worsening the pulmonary edema. So first one, we used the diuretic. So second important thing is the heart is failing. The heart is failing. So when the heart is failing, what should I do? I can do two things. Number one, heart is failing. So I can do two things. Number one, increase the working capacity of the heart. So if the heart is not pumping properly, increase the working capacity of heart. Yes, it is not able to pump, so increase the force of contraction. Another thing is when it is not able to pump properly and it is not working properly, you have to decrease the workload on the heart. Now, I told you there are two types of load on the heart. One is called preload because of venoconstriction, and one more is afterload, and that is because of artery constriction, that is arteriolar constriction. Now, how do I overcome this problem? How do I increase the workload? How do I increasing the working capacity of the heart and how do I decrease the workload? The working capacity of the heart can be increased by stimulating beta 1. So any drug which acts on beta 1, they can increase force of contraction. So the aim of therapy is to increase the force of contraction. The second aim of the therapy is to decrease the workload on the heart. How do I do that? By using vasodilators. So vasodilators are the one which can take care of the workload on the heart. So two major therapy, increase the force of contraction, and number two, decrease the workload by decreasing the preload and decreasing the afterload. How do you do that? Dilate the blood vessel, vasodilators. So what are the vasodilators we use? Number one, we have nitroglycerin. I write it as NTG. So can you tell me what is the other name of nitroglycerin? It is also called as glyceryl trinitrate, can be given IV. So if the patient is not responding to that, we can add one more drug, nesiritide, and it is also given as intravenous drug. Then we have a drug by the name sodium nitroprusside. Sodium nitroprusside. So remember as 3 N's: nitroglycerin, nesiritide, sodium nitroprusside. Now nitroglycerin we have extensively discussed in anti-anginal video. Sodium nitroprusside I will be discussing in antihypertensives. In this topic I will be discussing nesiritide in detail. Now sodium nitroprusside is also given in IV because it's an emergency and it's given IV only. So what is the drug nesiritide? We'll understand it now. The drug name is nesiritide. Nesiritide is a BNP analog. Nesiritide is a BNP analog. Remember, any drug ending with tide is a peptide. In pharmacology, usually drugs ending with tide are peptide and not given orally. This is not given oral. And obviously it's an emergency. It is given IV and it is used to manage emergency such as acute CHF. So that is the specialty. But what do you mean by a BNP analog? BNP stands for brain natriuretic peptide. So BNP stands for brain natriuretic peptide, and it has two important actions. The name itself is telling you it produces natriuresis. So natriuresis means loss of sodium in the urine. Now when you lose sodium, along with sodium, water is also lost. Sodium and water loss. So when there is sodium and water loss, there is decrease in ECF, that is blood volume. When you decrease the ECF, obviously there is decrease in workload on the heart. And that is what we require in the management of acute CHF, and we have achieved that goal. The second important is it stimulates a guanyl cyclase called membrane-bound guanyl cyclase. And what does it do? This will convert GTP into cyclic GMP. Now this cyclic GMP is a vasodilator, that is a smooth muscle relaxant. In the blood vessel, it causes vasodilation, and by doing that, it decreases preload as well as afterload. So again, here also they are going to decrease the workload on the heart. So this is what we require. Now compare this with mannitol. When we use mannitol increases ECF and it increases workload of the heart. So that is the reason why mannitol is contraindicated in where it is contraindicated in left ventricular failure as well as pulmonary edema, because it increases ECF, it increases the workload on the heart, and the heart will die further. That's the reason. So that is about nasiritide. It's a BNP analog. Until now, what we have achieved is number one, we took care of edema, that is congestion by diuretic. Number two, we took care of the workload by using vasodilator, the triple N, that is nasiritide, nitroglycerin, sodium nitroprusside. What is the third important aspect we need to manage? It is increase the working capacity of the heart. Increase working capacity of heart. Now, what is the receptor present on the heart? It's the beta 1. Now, when you stimulate beta 1, we all know that it increases force of contraction. So what should I do? I should use a beta 1 agonist. So the drugs should be agonist to beta 1. The question is, can we use beta blockers in acute CHF? Can we use beta blockers in acute CHF? So you have to pause the video and tell me whether it is used or not, yes or no. Obviously, no. They are contraindicated. They are contraindicated because in acute CHF, we want beta 1 to be stimulated and we want the heart to increase the force of contraction. But when I use beta blocker, they decrease the force of contraction and they will worsen the heart failure. And that's the reason they are contraindicated in acute CHF. Now, to understand the drugs which increase the force of contraction, what are the drugs which increase the force of contraction? Let me draw the diagram of the cardiac myocyte. Let me draw the diagram of cardiac myocyte. So let me draw it. This is the cardiac myocyte. Okay, yes. Now once I have written, in the cardiac myocyte, the receptor what is present is the beta 1. And we know that all the beta receptors are GS coupled receptor. Now when you stimulate the beta 1, it increases the cyclic AMP. So beta 1 is a GS coupled receptor which increases cyclic AMP. Now this cyclic AMP is broken down into 5-AMP, and the enzyme which does this is called phosphodiesterase 3. So the enzyme which converts this cyclic AMP into 5-AMP is phosphodiesterase 3. What a cyclic AMP will do? It will take calcium inside. So when the calcium enters inside, calcium will bind to troponin C. Now when it binds to troponin C, then the myosin and actin will combine and you see the contraction of the heart. That is, there is increase in force of contraction. So this is what we require. We need to increase the contraction, that is force of contraction. So this is your physiology. So when I give beta 1 is a GS coupled receptor. It acts by increasing cyclic AMP, which will allow calcium to enter. It binds to troponin C, and when it binds to troponin C, myosin and actin will combine and they will cause contraction of the cardiac myocyte, and there is increase in force of contraction. Now tell me, what are the ways where I stimulate so that the force of contraction increases? Number one, you can use beta 1 agonist. So the drug which stimulate beta 1, they are called beta 1 agonists. That can be used. Number two, you can inhibit the phosphodiesterase. So let me write them as phosphodiesterase 3 inhibitors. Now you can do one more thing. You can sensitize the calcium. They are called as calcium sensitizers. So the third category of drugs are called calcium sensitizers. So what do? They will sensitize the troponin C to bind to calcium more and more. Now what happens if troponin C bind to calcium more and more? The myosin actin are free and they can increase the force of contraction. Will they increase more calcium? No. With the available resource only, they will increase the force of contraction. So these are called calcium sensitizers. And we have a pump that is going to throw 3 sodium out and going to take 2 potassium in, and that pump is called sodium potassium ATPase pump. Now this can also be inhibited by certain drugs called cardiac glycosides. So they are called cardiac glycosides. Example is the drug by the name digoxin. So digoxin is a cardiac glycoside which can inhibit the pump sodium potassium ATPase pump. Now when you inhibit that pump, that will also contribute to increase in calcium, and when you increase the calcium, there is increase in force of contraction. We'll discuss that in detail when we come to digoxin. So basically there are 4 different group of drugs. One is beta 1 agonist, second phosphodiesterase 3 inhibitor, calcium sensitizers, and cardiac glycoside. We'll discuss one by one. Clear? Yes. So number one, we have the beta 1 agonist. So the beta 1 agonist drugs, what we use in acute CHF, they are dobutamine, dopamine, then noradrenaline, and sometimes we also use one more drug, adrenaline. So the first 3 drugs are very commonly used. Adrenaline in certain situation only used, and they all increase the force of contraction. And we have discussed these drugs in ANS pharmacology: dobutamine, dopamine, noradrenaline, and adrenaline. Moving on to second group of drug, they are called phosphodiesterase 3 inhibitors. They are called as phosphodiesterase 3 inhibitors. Now, what is the role of phosphodiesterase? I told you, cyclic AMP is broken down into 5-AMP, and that conversion is done by phosphodiesterase 3. Now, when you inhibit this, what happens? Cyclic AMP increases. What does cyclic AMP do? It has 2 roles. One is in the heart. I explained to you, in the heart it increases the calcium entry. When the calcium increases, there is increase in force of contraction. Now this force of contraction in physio we call it as ionotropy. So it increases the ionotropic action. Now in the blood vessel, if you increase the cyclic AMP, It is responsible for vasodilation. So it can cause vasodilation. Now, what was the purpose in acute CHF? I told you, you have to increase the working capacity. You have to increase the working capacity. And by vasodilation, you have to decrease the workload. So the drug is an ideal drug which can do both. So it can increase the working capacity, decrease the workload by causing vasodilation. These phosphodiesterase 3 inhibitors are also called as ionodilators. Now, why are they called as ionodilators? Because they cause ionotropy, that is, increase the force of contraction. They dilate the blood vessel, that's why they are called dilators, ionodilators. So they have an advantage. But what about beta 1 agonist? Beta 1 agonist, they only increase force of contraction. They only increase force of contraction. But another problem with beta 1 agonist, if you use them and if you infuse them continuously, they are known to develop tolerance. And if they develop tolerance, the next result what we have is phosphodiesterase 3 inhibitors. Now, once we know the mechanism of action, what are the drugs we have? The drug is ambrinone. So one of the problem with ambrinone is thrombocytopenia. It can produce thrombocytopenia. That means decrease in platelet count. Then we have inambrinone. Same drug, when you know ambrinone, this is inambrinone. Then we have milrinone. Now there are certain new drugs which have come to the market, which are phosphodiesterase 3 inhibitor. It is called enoximone. And one more is vesnarenone. These are the newer drugs. And remember, all of them end with renones. Vesnarenone. But enoximone has a different name. You have to observe that. So these are phosphodiesterase 3 inhibitors. So third one is what we call it as calcium sensitizers. So what are the drugs which are called as calcium sensitizers? The name is called levosimendan. And one more drug is called pimobendan. Now you read the name, their name end with endan. Now don't confuse with a drug called bosentan. Now they end with entan, and can you remember them? They are endothelin receptor antagonist. We use it in pulmonary hypertension. Now these drugs, levosimendan, pimobendan, what they do, they bind to troponin C and they attract calcium to bind and increase the force of contraction. Now what they do, with the normal calcium levels only, they increase the force of contraction. So with the normal calcium levels only, they increase the force of contraction. They will not increase more calcium and they will not increase force of contraction like digoxin. So these are calcium sensitizers, and one more property of them is additional property. Additional property is they also inhibit enzyme phosphodiesterase 3. So they are also phosphodiesterase 3 inhibitors, so we can also call them as ionodilators, and the name is levosimendan and pimobendan. So until now, we studied three group of drugs which can increase the force of contraction: beta 1 agonist, phosphodiesterase 3 inhibitor, and number 3, calcium sensitizers. Let us move on to the next category of drug. Number 4, they are called as cardiac glycosides. Cardiac glycoside, and in that we have only one drug that is used nowadays, that is called digoxin. Previously we had digitoxin, that is not used now. We have only one, that is digoxin. Now when I talk about digoxin, let us understand the pharmacokinetics of digoxin. Digoxin has a half-life of 40 hours. Now suppose you want to use digoxin in emergency, you want to achieve a target level. Now before I go to that concept, the drug follows narrow therapeutic index. The drug follows narrow therapeutic index. So can you tell me, if a drug follows narrow therapeutic index, is it safe or is it less safe or more safe? It is less safer. That means the therapeutic index is zero point 0.5 to 1.4 nanogram per ml. So you have to use a drug within this range. Now, what is the toxicity level for this? Toxicity level for digoxin is, if it is more than 2 nanogram per ml, this level can lead to digoxin toxicity. Suppose you want to achieve this 0.5 to 1.4 nanogram per ml in an emergency, there are two things you can do it. Either you can give it intermittently and then achieve steady state. Now, let me correlate general pharmacology here. Suppose a drug has a half-life of 40 hours. Can you tell me how many hours are required to achieve steady state? It's around 4 to 5 half-lives. That means, let me take 5, multiply it to 40, so it will take around 200 hours. That means approximately 8 days. So in emergency, if I give the drug like this, every half-life if I give the drug, it takes 200 hours to achieve steady state and you cannot get the target level. The other strategy, what we can do is we can give a dose called loading dose. So we can give a loading dose followed by maintenance dose. So this is what we follow in emergencies. For example, if I am using digoxin in atrial fibrillation, I cannot wait for 8 days for the drug to work. I have to give a loading dose followed by maintenance dose. Now suppose this is the graph, this is the time, and this is the plasma concentration of the drug. Plasma concentration, and you have to achieve the drug level between these two. So what we do is we give a loading dose. But if I give loading dose and stop, what happens? Later the drug level comes down and it will not work. So we follow it by maintenance dose. So this will achieve the concentration what we require between 0.5 to 1.4 nanogram per ml. So this is one of the application that asked in your exam. Digoxin has half-life of 40 hours. What is the message you get? The message is to give loading dose followed by maintenance dose. But can I give this steady state? Yes. If you are using it for chronic therapy like CHF and all, then you can wait. But acute conditions, you cannot wait. You have to give loading dose followed by maintenance dose. Another important for general pharmacology, you just want to correlate. Since the drug has narrow therapeutic index, should we do therapeutic drug monitoring? Yes. It requires therapeutic drug monitoring. And it also has high volume of distribution. If the drug has high volume of distribution, can we do dialysis? No. So if there is a poisoning, if there is a poisoning of digoxin or digoxin toxicity, there is no use of dialysis because it has high volume of distribution. So these are the important points you need to understand. It has a half-life of 40 hours and narrow therapeutic index. Toxicity is more than 2 nanogram per ml. If you want to achieve that 0.5 to 1.4, you can do it either intermittently, taking 4 to 5 half-lives, which takes longer. But in emergency, you can give loading dose followed by maintenance dose. It requires therapeutic drug monitoring. The reason is narrow therapeutic index, and there is no use of dialysis if there is digoxin overdose. So once I understand this, one more important point I want to highlight here is the drugs undergo renal elimination. So the drug is eliminated by kidney. So why should I know this point? The point I should know is, if the patient has renal failure, should I give the digoxin? You have to decrease the digoxin dose, or the patient will have digoxin toxicity. You may ask a question, sir, why are you going in detail for digoxin? Because digoxin usage is not so much in practice nowadays, but the usage in MCQs are still there. So that's the reason digoxin has to be studied in detail. Now moving on to the next important aspect, digoxin mechanism of action. What is the mechanism of action of digoxin and uses? Number one, digoxin is used in arrhythmia cases. It is used in two conditions, that is atrial fibrillation. It is also used to manage atrial flutter, atrial fibrillation and atrial flutter. Now, why are we using digoxin in this condition? Now, let me draw the heart here. This is the heart, and we know that there is SA node, then AB node, bundle of His, and Purkinje fibers. Now, the problem in atrial fibrillation and flutter is in atrial fibrillation, the atria is beating around the rate of 350 to 500 beats per minute, and flutter it's around 200 to 350. So here the impulses from the atria can come to the ventricle. If atria flutters or fibrillate, nothing happens because anyhow the blood is flowing down with the gravity. But the problem is when the ventricle starts fibrillating. So we don't want a ventricle to fibrillate or ventricular tachycardia to occur. So what we should do is we have to block the conduction from atria to ventricle, and that is done by AV blocking agent. So that is done by a drug which blocks it. So the digoxin mechanism of action is it has vagomimetic action. Vagomimetic action. So vagomimetic action is nothing but AV blocking property. Now remember, vagus is 10th cranial nerve and it is parasympathetic, and just memorize what does parasympathetic do in the heart. It decreases the heart rate, it decreases the conduction. So it decreases the conduction and it has AV blocking property. That's the reason we use it in atrial fibrillation and atrial flutter. The second important use of the drug is in CHF, but nowadays the use has come down, but still the questions come from this. Now, how the drug works in CHF? Let me briefly tell you the mechanism. It inhibits a pump called sodium potassium ATPase pump. So it inhibits a pump called sodium potassium ATPase pump. What happens when you inhibit that pump? There is increase in sodium inside the myocyte, that is cardiac myocyte. So when the sodium levels are increased, usually what is the role of sodium potassium ATPase? You have seen there, it has to throw sodium and take potassium inside, but when it is blocked, the sodium stays inside the myocardium, and what happens? There is increase in calcium, because calcium has to go out and sodium has to come in, because here there is inhibition of sodium calcium exchanger. So that will not work. Sodium calcium exchanger will not work, and that will increase the calcium. So more the calcium, there is increase in force of contraction. This is in brief. Remember, it inhibits a pump called sodium potassium ATPase pump. The sodium inside the cardiac myocyte increases, so that will not allow sodium calcium exchanger to work. So calcium will not go out, it stays inside. More the calcium, more the force of contraction. The same thing I will explain with the diagram here, that is in brief. Let me take the cardiac myocyte for you. So let me draw that. Okay, so cardiac myocyte. Now whenever the action potential comes, there is entry of sodium. Along with sodium, there is movement of calcium inside the cell. Now calcium is also stored in a reticulum called sarcoplasmic reticulum. So there are sodium which are coming from the sarcoplasmic reticulum, and that is the calcium. So these calcium and the calcium coming from sarcoplasmic reticulum, they combine with troponin C. Troponin C, and that will help in combining of myosin and actin, and there is muscle contraction, that is force of contraction. Now what happens after this is done? The sodium has to go out. How does sodium go out? Sodium will go out with the help of a pump which throws 3 sodium out and takes in 2 potassium. So it takes in 2 potassium and throws 3 sodium out, and that is called sodium potassium ATPase pump. What is it called? Sodium potassium ATPase pump. So I'll explain again. The sodium is entered, it has to be thrown out, and that is through this pump. Now, who has also entered? The calcium has come out of sarcoplasmic reticulum with the help of a receptor called ryanodine receptor 2. And after the contraction is over, it will again go back and stay in the sarcoplasmic reticulum. What about the calcium which has entered from outside? This calcium which has entered from the outside, will go out with the help of sodium coming inside. So with the help of sodium coming inside, this will go out, and that is called the sodium calcium exchanger. So let me write it again. It is called as sodium calcium exchanger. See, this is your normal physiology. So let me brief you again. Sodium enters, calcium enters. The sodium which has entered should leave it, and there is a pump called sodium potassium ATPase pump, which throws 3 sodium and takes 2 potassium inside. The calcium which has come from outside and the calcium released from sarcoplasmic reticulum, they bind to troponin C. So they are responsible for contraction of cardiac myocyte. Once the contraction is done, the sodium which has come from the sarcoplasmic reticulum will go back, and the calcium which has come from outside will get outside by the help of an exchanger called sodium calcium exchanger. This is the normal way. Now what happens when I start a patient on digoxin? When I give digoxin, what happens? When I give digoxin inhibits this pump. Digoxin inhibits the pump. Remember, digoxin and potassium are enemies. They don't bind to the same site. They bind to the different site, but when the potassium is high, digoxin cannot bind. But when potassium is low, digoxin can bind. So if the potassium is high, it decreases digoxin toxicity. But if the potassium is low, more digoxin binds, and that is responsible for increase in digoxin toxicity, because more digoxin can bind to the pump and it can block it. That is one thing. Now when you block this activity, what happens? Now the sodium is not able to go out. The sodium keeps on accumulating. Yes. So when the sodium keeps on accumulating more and more, when you block this pump, now what happens next is the calcium has to go out. Now the calcium has to go out and sodium should come from outside. But already the sodium is very high. The sodium which is coming inside will not be allowed. So this sodium calcium exchanger will not work. So if it doesn't work, the calcium will not be able to go out and sodium will not enter. So because already sodium is excess inside the cell. So the calcium keeps on accumulating more and more. So when more and more calcium accumulates, it will bind to more and more troponin, and more the calcium, more is the force of contraction. This is how the drug works. By increasing the force of contraction, how? By increasing the number of calciums available. So let me explain again. Digoxin inhibits sodium potassium ATPase pump. So sodium is not able to go out. It accumulates. When it accumulates more and more, it cannot exchange with calcium because already sodium is high inside and sodium from outside cannot come. If it is cannot come, calcium cannot go out, and calcium keeps on accumulating, and more the calcium, more the force of contraction. This is the mechanism of action in detail. But the problem is when you are keeping so much of sodium and calcium, it's like keeping an atom bomb inside your home. So the tissues can trigger anytime. So that's the reason digoxin toxicity can cause all types of arrhythmias. So digoxin toxicity can lead to all types of arrhythmias because this increase in calcium and sodium can trigger arrhythmia anytime. So that's the reason we see adverse effect arrhythmias with digoxin toxicity. So this is the basic understanding how the digoxin works. So we have understood digoxin, we understood the pharmacokinetics, we understood the mechanism of action and uses. Why we should go in detail? I told you one of the most important drug for your entrance exam, digoxin. Yes. So we understood the pharmacokinetic uses and now come to the adverse effect. Adverse effect of digoxin. Now the most common adverse effect of digoxin is the GIT upset. GIT upset, and that is your favorite: nausea, vomiting, diarrhea. Okay, I know most of you have remembered in pharma, nausea, vomiting, diarrhea, which is the most common adverse effect what we see with digoxin. Second problem is it can produce xanthopsia. Xanthopsia means the vision disturbance. Patient will complain of yellow vision. Patient will have yellow vision disturbance. Third problem is it can cause gynecomastia. Now, it's not a common problem, it's a rare problem, but it can also cause gynecomastia. Third important is digoxin overdose, or what we call it as digoxin toxicity. So this is the one which we need to go in detail and understand digoxin toxicity. Now, what are the factors which increase this toxicity? Factors increasing digoxin toxicity. Now, there are three factors which we need to understand which increase digoxin toxicity. So one is the drug factors, electrolyte abnormality, and certain diseases. Now the drug what are going to increase digoxin toxicity, they are thiazides or loop diuretics, then quinidine, then verapamil, amiodarone, then captopril, and a drug called clarithromycin. Now, what is the reason why these drugs will increase digoxin toxicity? Because these drugs, quinidine, verapamil, amiodarone, captopril, clarithromycin, they inhibit a protein called P-glycoprotein. So they inhibit P-glycoprotein, which is going to throw the digoxin out. So they interfere with elimination of digoxin, and they are responsible for that. Now you can remember the drugs by the mnemonic TQVACC. So you can remember as thank you vax. So we are thanking vaccine for COVID-19. So TQ for thank you, VACC vax. So thiazide, quinidine, verapamil, amiodarone, captopril, and clarithromycin. Now, why thiazide or loop can do this? Because whenever we use this, there is a electrolyte abnormality, that is hypokalemia. So hypokalemia, hypomagnesemia, and hypercalcemia, these are prone for digoxin toxicity, because you know that more the calcium, more the risk of triggering of action potential, more the risk of arrhythmia. So hypokalemia, hypomagnesemia, and hypercalcemia, they can increase digoxin toxicity. And if you remember, thiazides can cause the same problem. But loop diuretics can also cause hypokalemia, hypomagnesemia, but loop diuretics cause hypercalcemia. That's the only difference. But they can cause electrolyte abnormality, or any drug which causes this electrolyte abnormality like hypokalemia, hypomagnesemia, hypercalcemia, they can also increase the digoxin toxicity. But these are the major ones. Now coming to the diseases, I told you the drug is eliminated by kidney. So renal failure can increase the digoxin toxicity. Next, the thyroid dysfunction. Now, what do you mean by thyroid dysfunction? Thyroid dysfunction means both hypo and hyperthyroidism can increase the toxicity. Then myocarditis. myocarditis, and then WP, W syndrome. So these are the conditions who can increase the digoxin toxicity. Now, once we understand this, let us continue with digoxin toxicity. Now, whenever the digoxin toxicity occurs, it will manifest as arrhythmias. So digoxin toxicity can cause all types of arrhythmias. It can cause all types of arrhythmias. Except, do arrhythmias are not seen? What are the exception? Except number one, atrial flutter. Now the reason why atrial flutter is not seen is because digoxin increases atrial excitability. So what do you mean by increasing atrial excitability? The condition is even the patient develops atrial flutter. For example, I told you atrial flutter is between 250 to, around 200 to, it's around 200 to 350. So when I use digoxin, it increases atrial excitability. So from atrial flutter, the digoxin can make it into atrial fibrillation. So that is one reason why flutter is not seen, because it increases atrial excitability. Even the flutter occurs, suddenly it will shift to atrial fibrillation because it increases atrial excitability. But it blocks AV conduction. Second important arrhythmia that is not seen is Mobitz type 2. Now the reason why Mobitz type 2 is not seen, so this is the heart and this is the SA node, AV node, then bundle of S. Now Mobitz type 2 occurs below AV node. So this is seen below AV node and the drug will not act below this. And that's the reason this type of heart block, Mobitz type 2, is not seen. So all types of arrhythmias are seen except atrial flutter and Mobitz type 2. And I gave the explanation why it is not seen. Otherwise, just remember atrial flutter and Mobitz type 2 are not seen. The second important aspect is what is the most common arrhythmia in digoxin toxicity? The most common arrhythmia what we see is ventricular bigeminy. The most common arrhythmia what we see is ventricular bigeminy. Then what is the most specific or most characteristic arrhythmia? Most specific is atrial tachycardia with AV block. The most specific is atrial tachycardia with AV block. So in the exam, they will not give atrial tachycardia with AV block. Either they will give atrial tachycardia and ventricular rate has become normal or it has decreased, or they will give AV block with decreased ventricular rate. So these are the findings to tell there is digoxin toxicity. So most characteristic or specific is atrial tachycardia with AV block. How does it appear in the exam? Either they will give a heart block, or without heart block they can give ventricular rate has become normal or it has decreased. So these are specific of digoxin toxicity. So I told you in digoxin toxicity we see arrhythmias, and the most common arrhythmia what we see is ventricular bigeminy. Most specific or characteristic that is seen only with digoxin toxicity is atrial tachycardia with AV block. And all types of arrhythmias are seen except two, that is Mobitz type 2 type of heart block and atrial flutter. Now when the patient comes with digoxin toxicity or overdose, so how do we manage that overdose? Can you do dialysis? No. There is no use of dialysis. You cannot remove that because it has high volume of distribution. Second, do we have an antidote for that? Yes, we have an antidote. What is the name of it? The name is digibind. It is called as digibind, or it is also called by another name digifab, or it is also written as digoxin immune antibodies. So all are same drugs only. And recently this question came, digoxin overdose, what is your treatment of choice? So Digibind, also called as Digifab and digoxin immune antibodies, and these are not easily available. They have orphan drug status. So orphan drug status, that means they are not easily available. And because we don't see digoxin toxicity every day in our hospital, like OP poisoning, digoxin toxicity is very rare. But how do you manage the arrhythmias which occurs with digoxin toxicity? Suppose the patient has digoxin induced ventricular tachycardia. So what is the drug of choice for digoxin induced ventricular tachycardia? The drug of choice is lignocaine. The drug of choice is lignocaine. Suppose the patient has digoxin induced supraventricular tachycardia. What's the drug of choice? The drug of choice is beta blocker. For example, propranolol, esmolol, like that. So digoxin induced, if there is digoxin induced AV block or bradycardia, so what do you use? The drug used is atropine. What we use is atropine. So digoxin induced ventricular tachycardia, digoxin induced ventricular tachycardia, the drug of choice is lignocaine, SVT, beta blocker, AV block and bradycardia, the treatment is atropine. Now remember, you should not know DC cardioversion. No DC cardioversion should be done in digoxin toxicity. In digoxin toxicity should not be done. Right? So no DC cardioversion in case of digoxin toxicity. And many people ask me this question, sir, when to use potassium? Now potassium supplementation or infusion not in acute digoxin toxicity. So potassium should not be used in acute digoxin toxicity. If there is acute digoxin toxicity, don't infuse potassium, because in acute digoxin toxicity, potassium is already high. Potassium is already high, and that can lead to dangerous hyperkalemia. So don't give it. Then when to use potassium? If there is chronic digoxin toxicity and patient complains of tachycardia, then you can give potassium supplement can be used. So that is the use of potassium in digoxin toxicity. Don't give it in acute digoxin toxicity because potassium is already high. Chronic, it will not be high. You can give potassium and you can displace the digoxin out. So this is how we manage the digoxin overdose. Remember, digoxin is one of the important drug repeatedly asked in exam. Know the mechanism of action. In atrial fibrillation and flutter, it acts by AV blocking property. CHF, it acts by inhibiting sodium potassium ATPase pump and increasing sodium and increasing calcium, increasing force of contraction. Number 3, the pharmacokinetics, narrow therapeutic index. You require therapeutic drug monitoring for that. Then coming to the adverse effect, nausea, vomiting, diarrhea, xanthopsia, gynecomastia, but most important, digoxin toxicity. What factors increase it? What is the antidote for that? And how do you manage the arrhythmias associated with this? So these are different questions asked in your exams. So many times they will ask you what are the easy changes when we give digoxin. So when we give digoxin, there are certain easy changes what we see. So what are the easy changes? Number 1, the PR interval is prolonged. The PR interval is prolonged. So what is the reason why PR interval is prolonged? Because we know that digoxin causes AV blockade, so PR interval is prolonged. And the QT is shortened. and there is ST depression. So the ST depression looks like the reverse check sign. It looks like the reverse check sign, or it is called as the hockey stick sign. And then we see T wave flattening. T wave flattening. So these are the parameters what we see with digoxin. When the patient is given digoxin, please remember these heat changes are not going to tell you toxicity. This is seen with normal dose of digoxin. It is not a sign of toxicity. Remember, it's seen with normal dose. PR interval is prolonged. Suppose this is the P wave. Then we have QR, and there is the scooping sign. So this ST segment looks like this. So it looks like the hockey stick, this one. So it is also called as the scoop sign. So it is P, Q, R, and the ST looks like this. So it looks like the reverse check. So usually we write a tick mark like this, but it looks like this. So that's why it is also called as reverse check, or it looks like a scoop. It looks like a hockey stick. So it is called like that. So these are the normal EC changes what we see with a normal dose of digoxin. Clear? Yes. Until now, what I discussed is the management of acute CHF, and the role of digoxin in acute CHF is not there nowadays. Now let us discuss how do you manage the chronic CHF. So management of chronic CHF. Now chronic CHF is also called as compensated heart failure. Now what is compensated heart failure? Because whenever there is chronic CHF, there is decrease in cardiac output. Whenever the cardiac output decreases, the sympathetic system gets activated. So there is activation of sympathetic system. Now when the sympathetic system comes to the picture, it activates the alpha 1 and beta 1. So beta 1 increases heart rate, it increases stroke volume, and it can increase the cardiac output. Alpha 1 acts on the blood vessels, it causes vasoconstriction, and that will increase the preload by causing vein constriction. It increases afterload by constricting blood vessel, that is arterioles, causing afterload. Now beta 1 will also activate a pathway called renin, that is RAS pathway. Renin will give rise to angiotensin 2, and from there we get aldosterone. So aldosterone is going to cause sodium and water retention, and that will also responsible for increase in cardiac output. Now if you see this, when the heart is not pumping properly and it has compensated itself by increasing the cardiac output, then why should I interfere? When the heart is not producing the cardiac output, it has compensated itself, then why are we using the drugs? The problem is when you activate aldosterone more and more, this pathway gets activated. Number one, the fluid accumulation occurs. Number two, I told you in RAS pathway, aldosterone is the culprit which causes ventricular remodeling. It causes ventricular remodeling. Not only that, it causes myocardial fibrosis and apoptosis. So it can cause myocardial fibrosis and apoptosis. So what happens when you do that? Aldosterone increases the mortality in patients with CHF. Because once the heart changes the shape, it will go for permanent failure and the death rate increases. So in this chronic CHF, the purpose is to make the person live longer and to take care of edema. So how do we do that? What we can do is decrease the workload on the heart. So we can use vasodilators. So the vasodilators what are used are hydralazine. Hydralazine is a artery dilator. It's a artery dilator. And one more you can use is isosorbide dinitrate. It's a venodilator. So these can take care of the loads. Next, what we can do is you can block beta. We have beta blockers, or what you can do is ACE inhibitor or ARBs. You can use them. After that, you can use the only diuretic which decrease mortality are aldosterone receptor antagonist. Can you guess the name? Yes, it is called spironolactone and eplerenone. So guys, penultimately, our goal in chronic CHF is to decrease the action of aldosterone and decrease the workload on the heart so that the fluid accumulation doesn't occur. What happens if fluid congestion occurs? Patient will have dyspnea. He cannot do his day-to-day activities. He will have peripheral edema. So let us discuss when we know the basics. When you manage a chronic CHF, there are importantly what we need to do is decrease the mortality in chronic CHF, or you can tell it as increase the longevity. Longevity means same thing. If you decrease the mortality, they will live longer, or you can write it as drugs will decrease disease progression in chronic CHF. So what are the drugs which can do this job? The drugs are, you can remember by the mnemonic sub, SAB sub. So what is S for? S stands for spironolactone. Now why spironolactone? Because it's a mineralocorticoid receptor antagonist. What is the other name for mineralocorticoid receptor antagonist? Aldosterone receptor antagonist. So his brother eplerenone. And recently we have come up with one more S. They are called SGLT2 inhibitors. They are also known to decrease mortality in CHF. What are the drugs? Example are empagliflozin. And remember the end with gliflozin. Then dapagliflozin, canagliflozin. So these are the one. Now how come they will do this job? Because when you are losing sodium, you are losing glucose. So there is natriuresis. So loss of sodium, loss of glucose, there is loss of sodium and water. So edema decreases. And the trials have also shown that they decrease mortality in chronic CHF. Then A stands for the ACE inhibitor. And you know that they end with pril. So can you guess some drugs? Then ARBs and A end with sartan. Can you guess certain drugs? And then we have ARNI. Now what is ARNI? I will tell you. ARNI stands for this meaning. AR stands for ARBs. So the ARB that is used is valsartan. So AR stands for ARB, that is angiotensin receptor blocker, and NI stands for neprilysin inhibitor. So what is the name of this neprilysin inhibitor? And the name is sacubitril. The name is sacubitril. So we have valsartan plus sacubitril, and the combination is called ARNI. So ARNI is a combination of valsartan plus sacubitril. So what is the role of sacubitril? We'll discuss in the next slide. Okay, so we have the natriuretic peptide BNP, ANP. These are broken down by neutral endopeptidase. NAP stands for neutral endopeptidase. They are also called as neprilysin. So they will make this inactive. And in the beginning, I told you what is the role of ANP, BNP. They can cause natriuresis and they can also cause vasodilation. Now, how do I increase their level in the body? By inhibiting the neprilysin, and that is done by sacubitril. But this neprilysin is also going to degrade, inactivate certain other peptides. For example, bradykinin, and it is also going to degrade substance B. So when we use sacubitril, what is the risk? Can you take a guess? When I use sacubitril to a patient, what is the risk I am going to take? What is the adverse effect I am going to see? These bradykinin and substance P are not broken down, patient may develop angioedema risk. So there is a risk of angioedema like ACE inhibitors. Now, sacubitril usually is not combined with ACE inhibitor because they also cause angioedema. Sacubitril also cause angioedema. It is combined with valsartan. So this is called ARNI. So that is the second category of drug. So S for spironolactone, eplerenone, SGLT2 inhibitor, A for ACE inhibitor, ARBs and ARNI. What is B for? Now B stands for beta blockers. Now please understand, beta blockers are contraindicated in acute CHF. Why? Because they decrease the heart rate, they decrease conduction, they decrease the pumping capacity of the heart. You may ask a question, sir, when we are knowing that beta blocker decrease the force of contraction, will they not worsen the heart failure? Yes, they can. But they have done studies where beta blockers have shown to decrease the mortality. How? Number one, they inhibit renin. And when you inhibit renin, there is decrease in aldosterone. I told you aldosterone is the culprit responsible for mortality. And also they decrease the workload on the heart. So the heart can survive longer because they decrease the workload on heart. So these are the two reasons why beta blockers are used in chronic CHF, and they decrease the mortality. But since we know that they have a risk to decrease the cardiac output, we always have to start them with very low dose. Start with very low dose. And then we gradually increase the dose. First, we'll give the dose and see whether the patient tolerates it or not. How do I know patient has tolerated? If the patient we give and it doesn't develop any dyspnea symptom, it doesn't develop any weight gain because of edema, then he has tolerated. Then after 4 weeks, we will again increase the dose a bit. Usually the low dose is what we start is 1/8 of the standard dose we start. So we follow the formula that go low, we follow this, start low and go slow. So when you start a beta blocker, start it with low dose and gradually increase the dose. Go slow, don't be in a hurry because patient may end up with pulmonary edema, patient may end up with congestive symptoms. So this is the point. Now, what are the beta blockers? What we use in chronic CHF? They are bisoprolol, metoprolol, then a drug called carvedilol. And recently the nebivolol is also shown to be beneficial. The name is called nebivolol. So these are the beta blockers what we use in chronic CHF. Remember, they should be started with very low dose. If the patient develops congestive symptom, either we reduce the dose or we stop beta blockers. But what is the benefit? Benefit is they decrease the workload on the heart, so they decrease the renin activity and thereby suppress the activity of aldosterone. So remember the drugs which decrease the mortality or disease progression, the sub drugs. But in Afro-American population, there are one more group of drug which has shown to decrease mortality. African American population, and that is a combination of hydralazine plus isosorbide dinitrate. This combination has decreased mortality, and that is proven only in African-American population. And certain population, even ivabradine has shown to decrease mortality. In certain population. So these are the additional information, but remember basic 3 drugs are sub-drugs. In African American, hydralazine plus isosorbide nitrate, ivabradine in certain people, it has shown that effect. But main drugs are sub SGLT2 inhibitors, then spironolactone, ACE inhibitor, ARB, ARNI, and beta blockers. So that is how we manage chronic CHF. But if the patient develops congestive symptoms, we add digoxin. If the patient develops edema, we use loop diuretics. So if the patient develops congestive symptoms, so we want to increase the force of contraction. Some of the old school of thought, they start digoxin. Otherwise, digoxin is not touched. If the patient develops edema, so we use loop diuretics. They are most effective compared to thiazide diuretics. So this is what the management of chronic CHF. Okay. So in this video, we discussed what are the drugs used in CHF. So we differentiate acute CHF and chronic CHF. And please remember, in this topic, you need to keep in your mind digoxin in and out. And the drugs which decrease mortality in CHF, that has to be known. So thank you all.